Yes, good evening. I'm called Long Benadamain, and today we're going to talk about meningitis. So, meningitis, how would you define it? So, meningitis is just an infection or inflammation of the brain and the spinal cord. And there are different types of meningitis. There is what we call bacterial meningitis, and this is just the infection of the brain and the spinal cord caused by bacteria, and usually this is treated using antibiotics. Preferably someone could use ceftriaxone, or another one can use sulbactam. Now we also have TB meningitis, and this is just the infection and inflammation of the membranes covering the brain and the spinal cord, and usually the cause is that it's caused by tuberculosis. So with the treatment, you have to put someone on anti-TBs. Yes, and specifically today we are going to talk about cryptococcal meningitis. So how would you define cryptococcal meningitis? So this is just the infection and inflammation of the brain and the spinal cord, and it's usually caused by fungus. Cause Cryptococcus, usually it's by C. neoformans. And we had a case of a patient who came in, and that's the case we are going to talk about. So the patient who came in was called Opio John. John was 45 years old. He was a referral from Ogur Health Center 3. And so at the time when John came in, John had high-grade fevers. The attendant that brought him was complaining that 2 days ago, that he had episodes of convulsions, and then he had a stiff neck, and he had been receiving treatment from there for like 5 days. Then he was referred in here. So he was brought in here on the 12th of June 2026, and at the time when he was brought in, of course he had a stiff neck, he had high-grade fevers. When we did our general assessment, his Glasgow Coma scale was 13. He was confused. He was not aware of time and place. And we did a lumbar puncture. So when we did the lumbar puncture, he had high jetting. The cerebrospinal fluids were jetting, and of course we managed to pick 20 mils of the cerebrospinal fluids, and the color was not clear. So he has been with us in the ward. He was sent from emergency to the main medicine ward, and as of now he is stable. So I would briefly just want to talk about the pathogenesis of cryptococcal meningitis. So usually the source of this fungus is that it lives in the soil, and of course it majorly comes from droppings of like birds, and of course with the root, it's just that it's got from the spores, the spores that usually find its way straight to the lungs through inhalation, where as someone is breathing in and out, the tiny spores get to find their ways into the lungs, and so usually when that happens, someone gets to these spores, of course, get to multiply with time, and then they go into the bloodstreams. And when they go into the bloodstreams, they get to cross the blood-brain barrier. And when it crosses the blood-brain barrier, the brain then gets to be affected by this. And so when the brain gets damaged by this, we get to realize that with people who are immunocompromised, usually those whose CD4 counts are less than 100, the infection crosses the brain, and then when you do a lumbar puncture, you get to realize that they have high pressures. The jetting is usually high, and when by the time you keep on doing the lumbar puncture, the stiffness of the neck that was initially there then gets to improve, and the patient usually gets relieved as you continuously get to do this lumbar puncture. So the treatment plan for Cryptococcus meningitis, usually one, we get to put these people in the induction phase of the treatment. So the induction phase of the treatment, we get to put them on amphotericin B, and then of course in combination with the flucytosine. The flucytosine is given IV, and it goes for 14 days. Now as it goes for 14 days, we get to realize that we have to keep rehydrating her patient, because we know amphotericin B is a bit of an aggressive drug. So as it goes for more days, we have to keep rehydrating them at least a minimum of 1 liter per day of normal saline. So after that 14 days, we get to put them on of course, the consolidation phase. Now in the consolidation phase, we have to put them on the 8 weeks treatment, and in this case, we get to put them on a high dose of fluconazole, and we get to realize that this fluconazole at least gets to help in clearing most of the fungus in the brain and in the spinal cord. Of course, this treatment would go for the 8 weeks, and since it's a high dose, we get to realize that after those weeks, the 8 weeks, we would of course now go to the maintenance phase. Now in the maintenance phase, we would put them on the fluconazole, now the oral fluconazoles. Now with the oral fluconazoles, in this case, we are now lowering the dose of the fluconazole down, because in the consolidation phase, we had put them on a high dose. Now in the maintenance dose, we are going to taper down the treatment, and we are going to allow it to run in a lower dose. We are going to give them a lower dose of the fluconazole in this case. Now of course, we would always have to repeat the CD4 counts, because our patient John, when he came in, when we did because he was a non-ART patient who had defaulted treatment for at least 6 months. So when we consulted from the family, they told us that he had not been taking his treatment. He had abandoned his medication. So when we did his CRAG test, the CRAG test turned out to be positive. So after the CRAG test turning out to be positive, we repeated the test using the cerebrospinal fluid, the CRAG test with the cerebrospinal fluid, and it also turned out to be positive. So we took samples for culture and gene expert. We are still waiting for the results, but of course we also did some tests like CBC, LFTs, RFTs, and of which the CBCs are not looking so good. The patient has infections, but of course we have also put him on IV ceftriaxone 2 grams, and since he was complaining of a lot of pain, we have given him IV paracetamol, and since he was also vomiting, we have also put him on vomitine, and according to us, he is doing well on his treatment, and we are hoping that afterwards we are going to take him back on his ART treatment the moment he stabilizes, because as of now the stiff neck has improved, he's able to eat, and at least he's able to ambulate. So as of now his GCS has also improved, it's 15, and he doesn't really have much complaints, and the stiffness of the neck has also improved. He's able to turn around, and we are very hopeful that he's going to improve. As of now, we are awaiting to repeat his labs, but generally is improving. We have rehydrated him as much as possible to avoid, of course, to protect the organs, and we are continuing to do the tapping in alternate days at least, and of course the pressures have improved. The pressures of the LP has improved, it's now normal, and the color has cleared. Thank you so much for your time.